Please settle down. Assalamu alaikum everyone. It's Umama Shahid from Department of Anesthesia, MCMD BKMC Mardan.
And I am Ikramullah, also belonging to Department of Anesthesiology.
It gives me an immense pleasure to extend a very warm welcome to all of you on behalf of MCMD BKMC, who has clubbed us for the workshop based on difficult airway.
I welcome our honorable chief guest, Dr. Salman Malik, HOD, MMC Mardan.
I also want to thank Dr. Nasir Ali, Principal of MCMD BKMC, who has provided us this opportunity to make this event happen.
Lastly, I would like to thank the faculty and all my colleagues who are joining us here and also joining us on social media platform.
As you all know, the workshop is based on the agenda of difficult airway and its management.
A question will be arising in your mind that what's the purpose of this workshop? Being a healthcare professional, our topmost priority should be the life of a patient.
Difficult airway can sometimes be disastrous and fatal situation which can lead to the death of the patient. In order to avoid such circumstances, one should possess enough knowledge in the management of difficult airway.
I assure you that you people will find this workshop very helpful.
Let's start our event with the name of Allah. So I would like to call Muhammad Anas for the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. أقم الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك ربك مقاما محمودا وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعلني من لدنك سلطانا نصيرا وقل جاء الحق وزهق الباطل إن الباطل كان زهوقا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين إلا خسارا وإذا أنعمنا على الإنسان أعرض ونأى بجانبه وإذا مسه الشر كان يئوسا قل كل يعمل على شاكلته فربكم أعلم بمن هو أهدى سبيلا صدق الله العظيم.
Jazakallah. Observe the prayer from the decline of the sun until the darkness of night, and dawn prayer for certainly the dawn prayers with witness by angel. And say, my Lord, grant me an honorable entrance and honorable exit, and give me a supporting authority for yourself. And declare The truth has come and falsehood has vanished. Indeed, falsehood is beyond to vanish. We sent down Quran as healing and mercy for the believers, and it only increased the wrongdoers in laws. When we grant people our favor, they turn away, acting arrogantly, but when touched with evil, they lose all hope. So, O Prophet, everyone act in their own way, but your Lord knows best whose way is rightly guided. Now I invite our respectable principal to address our audience.
Bismillahirrahmanirrahim. It's really an honor and a moment of happiness that our college is arranging this kind of workshop for the first time. आप लोगों को पता है कि लाइट हेल्थ साइंसेस का जो शोबा है वो आजकल के दौर में बहुत ही ज़्यादा इम्पोर्टेंट है और उसमें एक कंटिन्यूअस मेडिकल एजुकेशन और अपडेटेड रहना ही बहुत इम्पोर्टेंट है, क्योंकि ज़ाहिर बात है इसमें दो चीज़ें बहुत इम्पोर्टेंट है, एक तो नॉलेज और दूसरा स्किल। मेरा ये ख्याल है कि इस तरह की वर्कशॉप जो हैं ये मुनक्किद होते रहने चाहिए और जो यंग जनरेशन है इसमें पार्टिसिपेट करना चाहिए, ताकि हम जो नई नई चीज़ें आ रही हैं, ख़ास तौर पे अभी आप लोग देख रहे हैं कि साइंस में आर्टिफिशियल इंटेलिजेंस का एक बहुत रोल है और मुझे ये उम्मीद है कि आने वाले दिनों में और आने वाले सालों में इसका रोल और बढ़ता जाएगा। तो इस तरह की वर्कशॉप्स मुनक्किद होनी चाहिए और ज़ाहिर बात है कि जो इससे रिलेटेड शोबे से ताल्लुक़ रखने वाले लोग हैं उनको पूरी तरीके से उससे आगाही हो। मैं आप सब लोगों का बहुत बहुत शुक्रिया अदा करता हूँ और ख़ास तौर पर मुंतज़िमीन का, जिसमें तैयब साहब और जितने भी स्टूडेंट्स हैं जिन्होंने दिन रात मेहनत करके इस प्रोग्राम को ऑर्गेनाइज किया है, सलमान साहब ने का जिन्होंने अपनी बिज़ी स्केड्यूल से हमारे लिए टाइम निकाला है, तो आप सब लोगों का बहुत बहुत शुक्रिया। थैंक यू सो मच।
Thank you, sir. Let's move towards our presentation. So I would like to invite Abdurrahman and his group.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Abdurrahman Khan and I am a student of BSc Anesthesia at CMT BMC Mandan. First of all, I am very thankful and highly obliged to Sir Tayyib that he gave me an opportunity to be a part of this valuable workshop. Before going to start my presentation, which is about the difficult airway, I would like to share the importance and significance of our workshop. So basically, in ancient time, most of the people think that anesthesia was a risky field, and most of the deaths that occur during an operation of a patient is due to anesthesia. So basically, in ancient time, if people think like that, so it is right up to some extent, because in ancient time there is a lack of knowledge, lack of expertise, and lack of availability of the advanced equipments. But now, in their time, if someone thinks like that, it is wrong, because everyone has equipped with knowledge and expertise, and there is availability of the advanced equipments. So बेसिकली जो हमारा कॉन्सेप्ट है और एक सोशल मैसेज है इस वर्कशॉप में लोगों के लिए, हमारी कम्युनिटी के लिए, वो यही है कि हम लोगों में अवेयरनेस लाना चाहते हैं ताकि लोग अवेयर हो जाए और जो एक गलत कंसेप्ट कम्युनिटी में एनेस्थीसिया के हवाले से बना हुआ है वो खत्म हो जाए। तो इंशाल्लाह हम इसी तरीके से अपने रिस्पेक्टेड टीचर के गाइडेंस में रह के इस तरह के वर्कशॉप सेमिनार ऑर्गेनाइज करेंगे और लोगों तक एक ट्रू और एग्जैक्ट नॉलेज एनेस्थीसिया की प्रोवाइड करने की कोशिश करेंगे। So now I will start my presentation, which is about introduction of difficult airway. So what is difficult airway? First, here is a picture which we have added. If you get a call to attend this case, तो आप लोगों का क्या ख्याल है अगर आपको इस केस के लिए बुलाया जाए तो आप लोगों की क्या नजरिया होगी इसके बारे में? So check your pulse rate. After that, we have outline in which introduction, difficult airway guideline, unanticipated difficult airway, difficult past mask ventilation. These are our introduction outlines. So as I told you, what is difficult airway? So difficult airway, a clinical situation in which healthcare provider who is skilled at airway management encounter difficulty with one or more standard method of airway management. Next, ये जो airway की definition है वो standardized नहीं है। मुख्तलिफ नेशनल गाइडलाइन में उन्होंने अपने तरीके से इसको एक्सटेंड किया हुआ है। So next we will move towards the different guidelines which are explained by. As a guideline, American Society of Anesthesiology guidelines जिन्होंने difficult airway को define किया हुआ है, वो ये है कि a conventional trained anesthesiologist experiences difficulty with the face mask ventilation of the upper airway, difficulty with the tracheal intubation or both. It means when a trained anesthesiologist, not even a technician or technologist which is not much experience in anesthesia. So it clears when a trained anesthesiologist experiences difficulty with the face mask ventilation or tracheal intubation or with both. So it is considered as a difficult airway. After that, the Canadian guideline explains the difficult airway which is an experienced provider anticipate or encounter difficulty with any or all face mask ventilation, direct or indirect laryngoscopy, tracheal intubation, supraglottic devices or surgical airway. So Canadian guideline clears when an expert anesthesiologist experience difficulty with the direct or indirect laryngoscopy or face mask ventilation or tracheal intubation. जब एक एक्सपीरियंस जो एनेस्थेसियोलॉजिस्ट होता है उसको कोई डिफिकल्टी ऑन आती है जब वो फेस मास्क वेंटिलेशन करता है या वो डायरेक्ट इनडायरेक्ट laryngoscopy करता है या वो tracheal intubation करता है, तो during this procedure when a conventional trained anesthesiologist experiences difficulty in that, then it will be considered as a difficult airway according to the Canadian guidelines. After that, we will move toward AHGPI, Association of Anesthetists of Great Britain and Ireland, which put forward the guideline for a difficult airway, which is the clinical situation in which anticipated or unanticipated difficulty or failure is experienced by the physician trained in anesthesia care, but not limited to one or more of the following: face mask ventilation, laryngoscopy, intubation using supraglottic airway devices, tracheal intubation, extubation, or invasive airway. So AAGBI clears that when a conventional trained anesthesiologist experiences difficulty during management of airway, which is either be anticipated or unanticipated. Anticipated mean कि वो डिफिकल्टी उसको एक्सपेक्टेड हो, उसको नजर आती है कि इसको ये डिफिकल्टी है, वो तो हर एनेस्थेसियोलॉजिस्ट को वो समझ आता है कि ये क्लियरली एक डिफिकल्ट एयरवे है। लेकिन एक होती है अनएंटिसिपेटेड डिफिकल्टी। अनएंटिसिपेटेड डिफिकल्टी अनएक्सपेक्टेड होती है, वो ड्यूरिंग फेस मास्क वेंटिलेशन एक एक्सपीरियंस एनेस्थेसियोलॉजिस्ट को आ सकती है, वो ड्यूरिंग इंट्यूबेशन एक एक्सपीरियंस एनेस्थेसियोलॉजिस्ट को वो पेश आ सकती है, और ड्यूरिंग सुप्राग्लोटिक एयरवाइज डिवाइसेस को पुट करने में उसको डिफिकल्टी आ सकती है। तो ड्यूरिंग प्रोसीजर जब एक कन्वेंशनल ट्रेन एनेस्थेसियोलॉजिस्ट को इस सारे मैनेजमेंट में कोई डिफिकल्टी ऑन और आती है तो AAGBI गाइडलाइन हमें ये सब कुछ क्लियर करती है। नेक्स्ट, व्हाट इज अनएंटिसिपेटेड एयरवे? सो अनएंटिसिपेटेड एयरवे के लिए जो नेशनल ऑडिट प्रोजेक्ट ऑफ द रॉयल कॉलेज ऑफ एनेस्थेटिस्ट एंड द डिफिकल्ट एयरवे सोसाइटी एग्जेक्टिव समरी 2011 एक्सप्लेन एज, जो ये दो 10 गाइडलाइन और जो नेशनल ऑडिट प्रोजेक्ट है उन्होंने पुट फॉरवर्ड की हुई है कुछ आउटलाइंस फॉर अनएंटिसिपेटेड एयरवे, कि हम अनएंटिसिपेटेड एयरवे को मतलब हम अनएंटिसिपेटेड एयरवे को किस तरह डिफाइन कर सकते हैं। सो द फर्स्ट वन पॉइंट इज कि द failure to access the airway. The second one is the failure to have a plan B or plan C when the initial plans are failed. The third one is failure to proceed with awake fiber optic intubation even when indicated. This one is very important. The fourth one is repeated attempt at intubation despite deteriorating oxygenation. The fifth one is the failure of emergency percutaneous cricothyrotomy. So these are the important outlines which was discussed by the fourth national project and the difficult airway society. Difficult past mask ventilation. So what is difficult past mask ventilation? It is not possible to provide adequate ventilation because of one or more of the following problems. So these problems are the inadequate mask seal, excessive gas leak, excessive resistance to the ingress or egress of a gases. जब inadequate mask seal हो या excessive gas leak हो रहा हो या excessive resistance to gas की ingress या egress में, तो इसको हम difficult past mask ventilation में count up करते हैं। The next one is difficult laryngoscopy. The inability to visualize a part of the vocal cords after several conventional laryngoscopy attempts by the trained anesthesiologist. जब एक ट्रेन एनेस्थेसियोलॉजिस्ट को लेरिंगोस्कोपी में डिफिकल्टी आती है तो वो डिफिकल्टी किस तरह की होती है, वो वोकल कॉर्ड्स को प्रॉपर्ली उसका एक व्यू जो है वो अचीव नहीं कर पाता, तो उसको हम टिपिकल लेरिंगोस्कोपी में काउंट अप करते हैं। लेकिन मैं श्योर कि ये लेरिंगोस्कोपी की जो अटेम्प्ट करता है वो एक ट्रेन एंड कन्वेंशनल एनेस्थेसियोलॉजिस्ट हो। जब अनट्रेन और अनएक्सपीरियंस टेक्नीशियन या टेक्नोलॉजिस्ट ऑफ एनेस्थीसिया होता है उसको हम टिपिकल लेरिंगोस्कोपी में काउंट अप नहीं करते। अब टिपिकल supraglottic airway ventilation. A group of airway devices that can be difficult to insert into the pharynx to allow ventilation, oxygenation and administration of the anesthetic gases without the need for endotracheal intubation. So it is not possible to provide adequate ventilation because of one or more of the following problems. So we will discuss these problems one by one. The difficult supraglottic airway placement. Supraglottic airway placement requiring multiple attempts. Inadequate supraglottic airway seals, excessive gas leak or excessive resistance to the ingress or egress of the gas. So these are the difficulties which are faced by a trained anesthesiologist during the placement of the typical supraglottic airway devices in a pharynx. After that, we will discuss the difficult tracheal intubation. As they define the difficult tracheal intubation is an intubation during which the insertion of the endotracheal tube take more than 10 minutes and are required more than 3 attempts by experienced anesthesiologists. The next one is the difficult tracheal extubation, which is defined as the loss of airway patency and adequate ventilation after removal of the tracheal tube or supraglottic airway from patient with known or suspected difficulties. After that, we will discuss the inadequate ventilation. So the inability of an assistant anesthesiologist to maintain the oxygen saturation is measured by pulse oximetry greater than 92%. Indicators of inadequate ventilation here, we will discuss it. Absence or inadequate exhale carbon dioxide. Absent or inadequate breath sound or absent or inadequate chest movement. Hospitatory sign of severe obstruction, cyanosis, gastric air entry or dilatation, decreasing or inadequate oxygen saturation. Absent or inadequate or exhale gas flow is measured by spirometry. Now, it is physiological difficult airway. The physiologically difficult airway is one in which the physiological pressure in the patient increases the risk for cardiorespiratory and other complications during the tracheal intubation and transition to positive pressure ventilation. These rearrangements are especially recognized in a critically ill patient but can also occur in otherwise a healthy patient, including obese, pregnant, pediatric patients who have certain physiological alterations. So this is all about my presentation, and next I would like to invite Ms. Umama to continue further. Thank you so much.
I hope you guys aren't getting bored. I assure you guys my topic is quite interesting. It's about the history of difficult airway. So let's move towards the history. Airway management has been in existence since ancient times. One of the earliest forms of airway management is described in ancient literature by means of tracheostomy. Egyptian tablets 3600 BC and Hindu scriptures 2000 BC reference and give descriptions of performing a tracheostomy. Even the great warrior Alexander the Great, it is said, performed a life-saving tracheostomy on the soldier with his dagger preventing his suffocation. And Titus described this in 100 AD. A tracheostomy is described as a horizontal incision between two rings to bypass airway obstruction. Galen, a Roman physician in 160 AD, described endotracheal intubation in a dead animal and ventilating its lungs. Vesalius performed the first actual reported tracheal intubation in 1543 in an animal. Trousseau and Trendelberg, native Germans, perfected and refined the technique of tracheostomy and intubation. Trendelberg in 1971 reported performing a life-saving tracheostomy to prevent blood inhalation during upper airway surgery and also the first intratracheal anesthesia in man. In 1878, McGowan reported the first elective intratracheal intubation for the anesthesia in human. He achieved this by packing the hypopharynx, hence blood and debris would not leak the airway. Joseph Ordwell developed a metal tube system that could be passed blindly to relieve airway obstruction in children, suffocated from the pseudomembrane formed with diphtheria infection. Rosenberg and Cohen administered cocaine as a local anesthetic to obtune the cuff reflex during intubation. Tracheostomy and intubation were broadly used during the First World War. McGill recognized the advantages of tracheal intubation. In addition, by his efforts, anesthesia has become an independent specialty. In 1913, the first anesthetic laryngoscope was invented by Jackson, and modified by Magel, Miller and McIntosh. In 1942, Curie was introduced as a muscle relaxant for abdominal relaxation during general anesthesia, and endotracheal intubation became routine in major abdominal and other surgeries. Now in 21st century, new more advanced video laryngoscopes and fiber optic scopes have been developed to assist us the airway management. Thank you. I would like to call Zen for further presentation.
Thank you, Mama Shahid. Bismillahirrahmanirrahim. Starting with the name of Allah, who is most merciful and beneficent. My name is Zainul Abidin from Discipline Anesthesia, College of Medical Technologies, Bacha Khan Medical College. I will continue further as my colleague explains introductions and history of difficult airway. Now I will discuss about the causes of difficult airway. The difficult airway is the most important cause of anesthesia-related morbidity and mortality. About 30% of death are associated with anesthesia is due to inadequate management of airway. The principal adverse outcome associated with difficult airway are death, brain injuries, cardiopulmonary arrest, airway trauma, and damage to the breathing. There are three major causes of difficult airway. We will discuss it one by one. First one is congenital causes. In congenital causes, first one is Pierre-Robin syndrome. In a Pierre-Robin syndrome, majorly three difficulties are associated. First one is these patients having receding chin. Second one, these patients have backward displacement of the tongue. And third one, having upper airway obstructions. Due to these patients facing difficulty with mask ventilations as well as tracheal intubation. Down syndrome. And Down syndrome is a congenital disorder in these patients having macroplugia, means these patients having enlarged tongues, as well as these patients having short neck. Due to these patients not achieve a proper alignment of axis for the sniffing position like oral, pharyngeal and laryngeal axis. So due to these patients facing a difficulty with intubation. Tracheal colon syndrome. This syndrome make patient malformation of facial bone. Due to these patients not properly seal the face mask. As we say that as a guideline, that difficult intubation, difficult airway are those in which patient having difficulty with the mask ventilation as well as in intubation. So tracheal colon syndrome, these patients have malformation of a facial bone. Most commonly the cheek bones, jaw bones and ear bone. Due to these patients not properly seal the mask. Cleft palate. They will associated with tracheal colon syndromes as well as Down syndrome. Due to these patients have facial abnormality and facing difficulty with intubation, craniofacial abnormality. These patients does not properly form the facial bone, so they does not properly seal the face mask and facing difficulty with the face mask ventilation as well as intubation. Apert syndrome. In Apert syndrome, these patients have two major abnormality. First one, craniofacial synostosis, in which the cranial bones and facial bone fuse abnormally. Due to this patient having difficulty in intubations. Acromegaly. In acromegaly, the patient having poor secretion of the growth hormones. Due to these patients having macroplugia, mean enlargement of the tongue as well as their pharyngeal as well as larynx are enlarged. To this patient having difficulty with intubation, anatomical cause. In anatomical cause, the number first one is short neck. Due to the short neck, the proper alignment of oral, pharyngeal and larynx axis does not achieve. Due to these patients having facing difficulty with intubations. Receding lower jaw. These patients are also having not properly sealed a face mask and facing a difficulty with the face mask ventilation. Macrognathia. In macrognathia, the patient having hypoplasia and a lower mandibular. Due to this patient having difficulty with intubation. Prominent maxillary incisor. In these patients, the interinsular space is a decrease in 6 cm. Due to these, the laryngoscopy as well as intubation are difficult. High arch plate. These are also associated with a difficult intubation as well as mask ventilation. Restricted mandibular movement. In the restricted mandibular movement, the temporomandibular joint, due to this patient does not properly open the mouth and having facing a difficulty with intubation. Acquired causes. Laryngeal stenosis. In laryngeal stenosis, the larynx are narrow. Due to these patients having facing difficulty with intubation. Neck and face swelling. In neck and face swelling, the movement of the neck are restricted, and due to these patients have difficulty with intubation and also having face mask ventilation difficulty. Neck contracture. Neck contracture are also known as post-burn contracture. Due to these patients having neck mobility are restricted as well as mouth movement, mouth opening. So they have difficulty with intubation as well as mask ventilation. Other causes are morbid obesity, intraoral tumor, instrumental cause, pregnant women, diabetes, old age with inflammatory disease, arthritis of neck, jaw and larynx. Anesthetic cause. Anesthetic cause are concerned inadequate preoperative assessment. When you does not preoperative assess a patient, you will face a difficulty with intubations. Inadequate preoperative preparation of the patient and equipment. Poor technique. When you apply the poor technique, you will face a difficulty with intubation or airway management. Poor experience staff, malfunction of the equipment. So you have a proper redundant system, mean you have spare laryngoscope as well as a spare endotracheal tube or other instrument which is used in a intubations. Inexperienced assessment. Thank you.
Thank you. It was all about introduction part. Further, I would like to invite Hamza and Shahid Group for proceed.
Thank you, sir. My name is Hamza Zafar and I am a student of BS Anesthesiology. Now we will discuss about airway assessment. Introduction. Before initiation of anesthetic care, airway assessment will be performed by the patient who is taking care of anesthetic management. The assessment of patient airway is an integral part of the pre-operative workup. Its purpose is to predict potential problem, allowing a management plan to be developed ahead of time and avoid an unanticipated difficult airway. Basically, the aim is to predict and therefore plan ahead for potential problems in two areas. Number one, laryngoscopy and intubation, and more importantly, ventilation, that is oxygenation, which means ease of, first of all, bag mask ventilation, which is predicted to provide positive ventilation to those who are breathing, not breathing and breathing adequately. Oxygenation with the supraglottic airway is a rescue technique. As a rescue technique just because failure of bag mask ventilation and endotracheal tube insertion. Oxygenation with infraglottic airway as a last resort. History. Look at the old anesthetic record. If they are available to see a problem with airway management were documented. In practice, this means finding comments on ease or difficulty of gas mask ventilation, laryngoscopy, and any special airway techniques or equipments that were used previously. You might even consider requesting record from a different hospital if airway management is expectedly to be particularly challenging and time allows. Ask the patient. Although it is unlikely that a patient will be able to provide details about why airway management was difficult in the past. Statements such as they were struggling to get the tube down or similar should obviously ring alarm bells for you. Previous interventions like head and neck surgeries, therapies, and potentially affecting the airway management. Aspiration risk, obesity, and obstructive sleep apnea. They both are independent risk factors for bag mask ventilation, examination, and clinical test. Like any diagnostic tool, an ideal method for preoperative airway assessment should have high sensitivity and specificity while maintaining a high predictive value. Disappointingly, no single test for airway assessment meet these requirements. Dental status. Get a short focus history from the patient about previous dental surgery. Cosmetic procedures such as veneers or implant for the upper and lower front teeth, like incisor, caries, and premolars, and removable or non-removable dental hardwares, caps and crowns, bridges, denture and partial denture, loose teeth, missing teeth, damaged or chipped teeth. Make sure you have tell the patient in the preoperatively that you might lose the teeth, protruding buck teeth. The edentulous patient. Edentulous patient are those patients that are easily to intubate but difficult to mass ventilate. Easy to intubate just because they have no teeth and mandibular atrophy of patient hair. Malampati score. Malampati in his original paper from 1985 demonstrated that the relationship between scoring system and ease of laryngoscopy. This is asked by asking the patient in a sitting or upright position to open his mouth and protrude his tongue maximally without phonation, with the observer being at eye level with the patient. The Malampati test gave us the idea about the relationship between tongue size, mobility, and size of oral cavity. This relationship is important because it somehow predicts how easily the tongue can be displaced by a laparoscope plate during intubation. This is the score in grade 1. You have seen there pilaris, uvula, short palate, and hard palate. In grade 2, there will be a uvula, base of uvula, hard palate, and soft palate. In grade 3, there will be soft palate and hard palate. In grade 4, there will be only hard palate. Grade 3 and grade 4 will be the best predictor for difficult intubation. Cormack and Lehanick classification. During conventional laryngoscopy, at best attempt, the best view of glottis will be seen. Cormack and Lehanick classification is divided into 4 grades. In grade 1, full exposure of glottis like anterior plus posterior commissure. In grade 2, anterior commissure are not visualized, only posterior commissure will be visualized. In grade 3, glottis only will be the seen. In grade 4, no glottic structure will be the visible. Here you can see the Malampati classification and Cormack-Lehanick classification. Both class 3 and class 4 in Malampati and class 3 and class 4 grade in Cormack-Lehanick will be the difficult predictor for the difficult intubations. Now I would like to invite Shahidullah for further presentation.
Thank you, Hamza Zafar. I am Ashani from Department of Anesthesia. My colleague Hamza Zafar discuss you about typical intubation diagnosis test, a predictive test. I will further continue that mouth opening enter incisor gap. The enter incisor gap is the distance in centimeter between the patient upper and lower incisor. We asked to the patient can insert 2 and 3 fingers between their upper and lower incisor. Use your own finger for more consisting measurement from patient to patient. And if you do make one time effort to measure your personal finger breadth, and remember the centimeter values for 2 and 3 fingers. Enter incisor gate if greater than 5 centimeter, easily intubate. A greater than 4 centimeter, easily insertion of supraglottic devices. The cutoff value for enter incisor gap is 2.5 to 3.5 centimeter. At less than 2.5 centimeter, difficulty will occur during intubation or face mask ventilation or supraglottic airway devices insertions. Below 1.5 centimeter, one finger breadth in a majority of people, insertion of a video laryngoscope blade will be impossible. Thyromental distance. Thyromental distance is the distance from mental prominence, tip of the mandible, and thyroid cartilage, also called Adam's apple, during maximum head extension with the mouth closed. Which values are concerning are reassuring. Thyromental distance got a value for predicting easy or difficult airway. Management does not exist or at least disposed. However, the TMD of 6.5 centimeter or greater is rarely associated with difficulty. अगर thyromental distance की वैल्यू 6.5 से ज़्यादा होता है तो easily intubation. Less than ये cut off value है 6.5 centimeter. 6.6 centimeter से जब below होगा, it will be anesthesiologist suffer with difficult intubations. See in this picture, thyromental distance, tip of chin, Adam's apple, and the distance between them 6.5 centimeters. Temporal mandibular giant mobility we see by two tests, upper lip bite test and jaw contractions. Upper lip bite test, lower incisor bite above verminal line border of upper lip, तो हम score 1 देंगे. Lower incisor bite verminal border of upper lip, score 2. Unable to bite upper lip, 3, तो हम 3 score देंगे. 1 and 2 score इसमें difficult intubation होगा. Neck mobility, sternal distance and mobility of atlanto-occipital giant movement. The sternal distance is the distance between the mental prominence, the lower border of the chin, and the sternal lobe with full head extension and closed mouth. A value, cut off value 13 centimeter, if less than the anesthesiologist suffer from difficult airway. Like see this picture, sternal distance 13 centimeter है. Transnasal flexible endoscopic laryngoscopy. Nasal के through flexible endoscope हम डाल लेते हैं पेरेंट्स की और जो larynx होता है इसकी एग्जामिनेशन की, वहाँ पे ट्यूमर है या एडिमा, एब्सेस, टॉन्सिल, हाइपोट्रोपी एंड ऑब्स्ट्रक्टिव एयरवे है तो हम इसके थ्रू डायग्नोस कर सकते हैं. लेमन स्कोरिंग सिस्टम है. लुक एक्सट्रीमली फेशियल ट्रॉमा है कि नहीं है, बग ट्रीट है कि नहीं है, कंजेनिटल एब्नॉर्मलिटीज है कि नहीं है. इवॉल्वेट द एंटर इंसिजर गैप हम देख लेंगे कि 6 सेंटीमीटर से ज़्यादा है कि नहीं है. फिर हम देख लेंगे हाइड्रोमेंटल डिस्टेंस हम देख लेंगे और थायरॉइड डिस्टेंस हम देख लेंगे कि 4 सेंटीमीटर से ज़्यादा है कि नहीं है. अगर 6 सेंटीमीटर से ज़्यादा हो और 4 सेंटीमीटर से ज़्यादा हो, इट्स मीन दैट इजी इंट्यूबेशन इजी. Wilson risk score, weight less than 90 kg, 0 score देंगे हम. 90 to 110 kg, 1 score. अगर 110 kg से ज़्यादा हो तो 2 score हम देंगे. 1 to 0 score एक पेशेंट के आएगा इस क्वेश्चनियर के थ्रू, तो means that it is normal intubation. अगर 2 to 3 की होगा तो फिर हम देंगे कि it is डिफिकल्टी की तरफ जा रहा है। अगर 3 से ज़्यादा होगा मीन्स 4, 5 होगा, 6 होगा, इट मीन्स दैट डिफिकल्ट इंट्यूबेशन। अदर पेशेंट फीचर थे फेशियल हेयर, बियर्ड, स्मॉल माउथ है, आर्च प्लेट है, शॉर्ट नेक है, रिसीविंग चेन एंड प्रोट्रूडिंग बग टीथ है। टेस्ट कंपैरिजन हम कर लेते हैं तो अमेरिकन सोसाइटी ऑफ एनेस्थीसियोलॉजी एंड BGA ब्रिटिश जर्नल एनेस्थीसिया वो कहते हैं कि मॉडर्न पट्टी इज द गोल्डन टेस्ट फॉर ईयरली असेसमेंट। But some other countries like New Zealand, Australia, he said that thyromental distance जो टेस्ट होता है ये गोल्डन टेस्ट। मोस्ट सेंसिटिव मॉडर्न पट्टी है, 65 to 81 इसकी सेंसिटिविटी है, स्पेसिफिसिटी 66 to 82 है, और प्रेडिक्टिव पॉजिटिव प्रेडिक्टिव वैल्यू 8 to 9%। As a references, it's all about airway because airway matters.
Now it comes to the most important part of the lecture, difficulty airway management. So this would be presented by our colleague and Dr. Salman Malik. The first portion would be presented by Mohammad Anas and the second portion would be presented by Dr. Salman Malik along with a practical performed by Dr. Salman Malik. So please Anas, come and give your presentation.
In the name of Allah, the most merciful and beneficent. Greeting to all of you. I am Muhammad Anas, the student of anesthesiology at College of Medical Technology, BKMC Mardani. First of all, I am very thankful to the chief organizer of this workshop, Sir Tayyib, for such a honor and giving me this opportunity. And I also express my thankfulness and respect to the patronage chief, principal Dr. Nasser Ali and all faculty members for joining us and supporting us. Now let's get started. As you know that our colleague already discussed about the introduction to the difficulty airway management, and then scoring system has also been discussed. For further continue, now I will discuss the difficult airway management. So these are our outlines for today's presentation. At the end of this presentation, you will be able to learn about how to prepare and plan for difficult airway management. Along with the 4 categories of difficult airway management, you will be also able to aware about the different techniques for difficult airway management. And last but not the least, you will be also able to identify and recognize about the difficult airway management for anticipated difficult airway, unanticipated difficult airway, and physiological difficult airway, which will be presented by Dr. Salman. These are some prerequisites. So the key management for difficult airway is preparedness, in which the utmost importance is given to the personal training and education, as the continuous education and training about the difficult airway management is a core for anesthesia profession. Along with it, one should ensure the checklist, appropriate drug, appropriate equipment should be immediately available, and the proper teamwork should be established. Along with it, the assessment of the patient is very necessary, because when the potential problem is identified, which enable us to adopt a specific strategy for managing difficult airway which can minimize the risk and complications. And last but not the least, the cognitive skill and situational awareness of the practitioners is very important because the difficult airway frequently occur and cannot intubate, cannot ventilation situation is not a never event. As you can imagine, this is a very stressful condition for anesthetist and could be a nightmare for anesthetist. And in these circumstances, even a single task can be performed and even a single decision can't be taken. So, maintenance of the technical skills along with the psychological skill is very important for the managing difficult airway. These are the some essay recommendations for preparation of difficult airway management. Ensure the portable storage unit is immediately available, and if the suspected difficult airway, so ensure the skillful individual is immediately available and inform the patient or responsible person about the special risk or procedure pertaining in the difficult airway management. Then properly achieve the specific position of the patient, and supplemental oxygenation should be given if feasible. So give the supplemental oxygenation throughout the procedure, including initiating the procedure, during the procedure, and also during the extubation. And according to the ASA guidelines, you should be also ensure the ASA standard for the basic maneuvering is performed. You should ensure that it should be immediately available. So these are the basic three pillars of airway management. All our techniques, airway maneuvers, and all safety management revolve around these three pillars. Number one, patency. Airflow integrity should be maintained. Protection against aspiration is also necessary. And last but not the least, the assurance of oxygenation and ventilation should be mandatory for the safe airway management. Along with these three pillars, practitioners should also ensure to prevent the iatrogenic trauma. Don't overcome the mask, misplaced mask on the patient face to avoid the facial trauma. Gently insert the supraglottic airway and oral airway. Don't lever the laryngoscope over the upper incisor to avoid the dental trauma. Gently insert the ETT in a rotatory manner to avoid the tracheal trauma. Don't insert with a force and avoid the troublesome in multiple attempts to prevent the post-op incidence of sore throat. Keep the stylet distal end proximal to the distal end of ETT, and don't overinflate the cuff. Don't forget to deflate the cuff on extubation. Now these are the techniques for difficult airway management. It's not necessary all the time to secure the airway through tracheal intubation, but the supraglottic airway devices, face mask ventilation can also be considered and utilized in the case if the condition of the patient and duration of the surgery is suitable. And improvement of the difficult airway relies on the optimized mask ventilation, safe oxygenation time, prompt surgical airway in response to the severe hypoxia in the case if the non-invasive intervention is not effective. Now, in these techniques, the first is the pre-oxygenation, which is also called denitrogenation. It's the primordial for safe airway management. Optimal pre-oxygenation maximizes the FRC, which can increase the safe oxygenation time and increase the oxygen reserve. This can also be achieved by the reverse Edinburgh position and also by applying the PEEP before the tracheal intubation. You can see this figure. It is about the pre-oxygenation in normal patient and obese patient. After the single dose of propofol, you see that if pre-oxygenation is given to the normal patient and he's suffering from the cannot intubate, cannot ventilate situation. After the rapid fall in desaturation, the spontaneous breath can be regenerated. But in obese patient, the pre-oxygenation is not much effective, and if he suffer from the cannot intubate, cannot ventilate situation, so his saturation will be formed and spontaneous breath will not be regenerated. And according to this study, which we have cited, that the pre-oxygenation is not time dependent, but it's dependent on minute alveolar ventilation as well as the inspired oxygen concentration and performance of the slow breathing generate adequate ventilation. Now, optimal pre-oxygenation should be confirmed for the patient. It is confirmed through the capnography, and it will be said that pre-oxygenation is optimized if the expired concentration of oxygen is 80 or more than it. But this pre-oxygenation and expired oxygenation should also be confirmed first by you see that this expired this expired gas is truly from the alveoli, so you should also consider the expired carbon dioxide first. If the patient is not hyperventilated and expired carbon dioxide is 30 mmHg, so the pre-oxygenation is optimal. If the end-tidal carbon dioxide is below 30 mmHg and the patient has not hyperventilated, so in this case your optimal pre-oxygenation has not been achieved. This is the advanced technique, transnasal humidified rapid insufflation ventilated oxygen. TRIVE is a novel method for delivering high flow rate, about 70 liters per minute, and it can provide the apneic oxygenation through the process of tracheal intubation. This result a change from the stop-start approach with the re-oxygenation between intubation attempts, and it can also reduce the work of breathing. This is the TRIVE. It can be given through the high flow nasal oxygen cannula. Now we will discuss about the airway opening maneuvers. It covers the basic three pillars. First pillar, airway patency. So here are the two maneuvers: head tilt, chin up, chin lift, in which the one hand should be placed on the forehead of the patient and second should be below the chin. And the second maneuver is jaw thrust maneuver. इस jaw thrust maneuver के जरिए हम पेशेंट की एयरवे पेटेंसी को इंश्योर कर सकते हैं, और जो हेड चेन लिफ्ट अप मैनेवर है ये नॉर्मल पेशेंट में भी यूज हो सकता है, लेकिन जो जॉ थ्रस्ट मैनेवर है ये हम बेसिकली उन पेशेंट में यूटिलाइज करते हैं जिसमें नेक एक्सटेंशन वो रिस्ट्रिक्टेड हो. If the patient airway obstruction is not relieved still by these maneuvers, chin lift, head up and jaw thrust maneuver, so we can also utilize the airway adjuncts like oral airway and nasal airway, which can add the face mask ventilation as well as relieve the obstruction. These are the basic four categories for the difficult airway management. First is the face mask ventilation, second is the supraglottic airway device, third is the tracheal intubation, and second is the emergency front of neck axis, which includes the surgical cricothyroidotomy as well as tracheostomy. First is the face mask ventilation. So walk before you run. Same the case here, that face mask ventilation should not be underestimated. One should be skillful in a face mask ventilation before being expert in the tracheal intubation. As you know that face mask ventilation is the rescue technique upon failure of the tracheal intubation, so face mask ventilation should be optimized. Face mask ventilation can be optimized through selection of the appropriate size and firmness of the face mask, as well as different techniques can also help in the optimization of the face mask. According to these studies, two-hand mask ventilation using VE techniques, which you can see in the picture, might be more efficient than CE technique in the patient who potentially have difficult mask ventilation. Study has also been shown that mask ventilation with the head rotation to the side about 15 to 20 degree is more effective than head in the neutral position, probably due to the more patent airway. Difficult mask seal. बाज़ मास्क सील में डिफिकल्टी आती है और इसकी वजह से एयरवे ऑब्स्ट्रक्शन अगर हो सकती है तो कंटिन्यूअस एफर्ट करना चाहिए कि हम पूरी तरह मास्क को सील करें और हमारा फेस मास्क वेंटिलेशन ऑप्टिमाइज हो. Ambu bag has the advantage that has no flow is required to reinflate the reservoir bag between the breaths. This is especially useful for providing ventilation in an emergency outside setup. But with mask ventilation has also some cons because it have a risk of gastric reflux should be considered. Difficulty can be diagnosed when there is an inadequate chest movement despite high airway pressure in the case of obstruction or very low pressure in the case of deep. And capnography and spirometry can detect these optimization of face mask ventilation. Difficulty with the face mask ventilation can be due to the failure to maintain patent airway in the case of obstruction, which is more commonly problem. Laryngeal obstruction, either laryngospasm below the larynx and trachea, bronchi, and larynx. Supraglottic airway devices. It's the appropriate rescue plan for difficult mask ventilation or intubation. If the rescue supraglottic airway device is performing effectively, it could be remain in situ. Consideration for this include the level of confidence and ongoing performance, urgency and nature of the risk of aspiration and complexity of further airway management in the event of supraglottic. Any preceding vigorous face mask ventilation may have insufflated the stomach, resulting in the increase in intragastric pressure and further increase the reflex. If the patient can woken up, this should be considered. It's also be possible to intubate the patient via supraglottic airway devices. If the laryngeal mask airway fails, so nasal airway directly connect to the breathing circuit can provide adequate ventilation. इसी तरह हम ट्रैकियल ट्यूब को फेरिंक्स में इंसर्ट करके उससे भी वेंटिलेशन को ऑप्टिमाइज कर सकते हैं. Tracheal intubation. Direct laryngoscopy, which is a traditional method for lining up the three planes of the mouth and glottic view can be visualized. The ideal position for it is the flexion of the neck, flexion of the base of the neck with the head extension, which also called sniffing position, but according to the new study, it can also called flex extension. It is possible and variable in the normal patient, but in clinical practice, you face the obese patient. So for the obese patient, the sniffing position is not effective. So then you should apply the round position, which can be effective for the securing the airway. Difficult laryngoscopy. Don't be overconfident. If you feel difficulty, so change your technique and transition in a timely manner to prevent further injury and complication. If the difficult laryngoscopy, so assistance, ensure the assistance should be immediately available. The patient should be adequately paralyzed position should be adequately achieved. Either in normal patient, sniffing position will be achieved. If it's an obese patient, round position will be achieved. If the actual place and epiglottis view, you can't place the valvula, so birth pressure should be applied. If the Cormac-Lehan score is 3 and 4, so Bauji can be utilized. And if any difficulty, so blade size can be changed to pass the tube. And suctioning any secretion or blood to improve the view of also crucial. These are the different sizes of the blade, different handle sizes, polio blade, and also a short handle which can be also available in the obese patient, pregnant female. Here you can also see the hyperangulated blade, normal Macintosh blade, and the angle of the view. Here the McCoy blade, which is basically on the Macintosh blade, and view can be also optimized through it. Here below is the hook, which can be inserted between the blade and handle. It is called Holland hook, and it can minimize the dental trauma. Rapid sequence induction. Basic theme and goal of the rapid sequence induction is to maximize the FRC, ethnic oxygenation, safe ethnic oxygenation time, and minimize the time between the induction and tracheal intubation. So here the summary about the rapid sequence induction. Preparation should be done, pre-oxygenation should be done for the 5 minutes, while nasal cannula pre-treatment should be done, paralysis with the simultaneously induction, protection through applying the cricoid pressure and placement of the ETT tube and confirmation. Select maneuver, which is also called cricoid pressure, is helpful in the rapid sequence induction. The 10 Newton force is applied even the patient is awake, and will be gradually increasing up to 30 Newton when the patient is subconscious, which can prevent the contamination during period between loss of consciousness and placement of the cuff tracheal tube. Cricoid pressure has also been shown to prevent the gastric distension during mask ventilation and was originally described for this purpose. Gentle mask ventilation after the application of cricoid pressure and before tracheal intubation prolong the time to desaturation. The most useful in those with a poor respiratory reserve, sepsis, or high metabolic requirement, and also provide an early indication of ease of ventilation. Although cricoid pressure provides the physical barrier, but it can also reduce the lower esophageal sphincter tone, so possibly make the regurgitation more likely. The cricoid pressure can also improve the view of direct laryngoscopy, but many reports demonstrating that often poorly applied. So, due to the poor application of cricoid pressure, mask ventilation, direct laryngoscopy, or supraglottic airway devices may be more difficult. And in these circumstances, in the rapid sequence induction affair, so the second generation LMA may be preferred due to the greater protection against aspiration. Video laryngoscopy. Although in the now era, it is preferred that it should be a first plane to intubate the patient while video laryngoscopy, because it provides the apneic oxygenation together with the even better effective ventilation simultaneously during intubation. Means that it provides the apneic oxygenation during the multiple attempts or during the change the planes. Video laryngoscopy can be used in conditions like flexion deformity, restricted neck movement, or the tumor like goiter, etc. Or it can be also utilized in the trauma in which manual and line mix stabilization should be necessary. Video laryngoscopy for the awake intubation with a topical local anesthetic is emerging as alternative method for awake tracheal intubation. According to the systemic review, that video laryngoscopy result in the improved view of larynx, improve the ease of use, decrease the airway trauma, and reduce the failure chances. But with the video laryngoscopy, we obstacles some difficulties which can be handled. First, with the video laryngoscopy, it's difficult to direct the tracheal tube into the glottis. With the continuous practice, this skill can be enhanced. Or if you are using a non-channel video laryngoscopy like McGrath, Gladstone, so Bauji and Stylet can be helpful in this condition to direct the tube to the glottis. Another problem may be hold up at the glottis inlet on the structure such as epiglottis or arytenoid cartilage. Rotating the tracheal tube may overcome the obstacle, change the angle of approach and direction of the lever. Difficult intubation. There is a close relationship between difficult intubation and airway trauma. Predictive difficult intubation is usually handled well as awake intubation is an option. Keep in mind that failure of oxygenation rather than intubation that cause the harm. Flexible bronchoscopy intubation. Flexible bronchoscopy intubation have advantages for the anticipated difficult airway. It has a side port for suctioning, which can also be utilized for supplemental oxygenation, for the topical local anesthetic. It has also a scope which can be maneuvered by rotation and directing the tip up and down with a thumb lever. If there is no risk, so awake fiber optic intubation can be performed, but the procedure is well tolerated with effective topical local anesthetic and handling of the scope in conjunction with ongoing oxygenation. Sedation is often used for the patient comfort, but this should be carefully titrated as the condition could deteriorate. Awake tracheal intubation can be safely abandoned without having compromised the airway through the anesthesia or neuromuscular blockage. The patient should be assessed for cooperation because awake tracheal fiber optic intubation cannot be performed in the cognitive impairment or anxiety. Awake fiber optic intubation is a gold standard technique which can preserve the spontaneous ventilation along with the patient protective airway reflexes. Here are the picture you can see the fiber optic intubation is performing. This is a DOS guideline for awake tracheal intubation technique. Sedation should be given by using midazolam or fentanyl. Topicalization should be done by using local anesthetic spray, and phenyl can be used if you are using the nasal route. Oxygenation should be performed as we also discussed the thrive technique. High flow nasal oxygenation should be given by high flow rate 70 liters per minute and perform the procedure. Beside with the topicalization, there are some nerve blocks which can also help us to perform the awake tracheal intubation. The glossopharyngeal nerve block can be performed and superior laryngeal nerve block can be performed. So we should keep in mind these things. There are some limitations for fiber optic intubation like tumors, distorted anatomy, or the nerving or below the level of the glottis. So in these clinical scenarios, supraglottic ventilation, jet ventilation, or through narrow catheter or front of the neck axis may be required. You should don't place the tube, don't pass the tube, but place the tube. So keep in mind about the undetected esophageal intubation still save a life. No trace, wrong place. ये एक स्टडी उठाई गई है जो 2019 में एक केस हुआ था। एक सिंपल प्रोसीजर थी, अपेंडेक्टमी थी और पेशेंट कोई रिस्की पेशेंट नहीं था, लेकिन ड्यू टू द अनडिटेक्टेड एसोफेजियल इंट्यूबेशन पेशेंट हैज डाइड। सो अगर कैप्नोग्राफी में कोई ट्रेस नहीं आ रहा तो इट मींस दैट यू हैव wrongly placed the tracheal tube, because in the cardiac arrest there are some errors in the capnography, and if you are using a CPR, so this graph can also be increased further. But in the case of wrong place of the tube, there will be no trace. There are some recommendations for extubation of difficult airway. Extubation strategy will depend on the procedure, other preoperative circumstances. Assess the patient readiness for extubation. Skillful individual should be required. Appropriate time and location. Because intubation is the skill while extubation is the art. So one skillful individual should be present to assist extubation when feasible in the appropriate time and location. Maximize the use of airway exchange catheter with the pediatric patient. Evaluate the risk and benefit of awake extubation versus extubation before return to the conscious. When feasible, use supplemental oxygenation throughout the extubation process. Assess the clinical factors that may produce an adverse impact on ventilation after the patient has been extubated. There are some difficulty which we can face during extubation. The 1/3 of the airway event can take place in the emergency or emergence or extubation. The commonest cause is obstruction, difficult intubation or blood in the airway, predisposed to the complication around extubation. This is a DAS guideline for extubation. You should first plan, then prepare and assist the patient. If there is a lower risk, so you can extubate. If there is a higher risk, so you can place the tube until the patient deterioration condition has been diminished, or either the patient can be shifted to the ICU unit. According to the DAS guideline of extubation, at-risk algorithm suggests some advanced extubation technique as well as consideration the keeping the patient asleep and extubating when the condition are more suitable. This is the front of neck axis. All anesthetists should be trained to perform a surgical airway. Cricothyroid membrane should be identified before the procedure, either through landmark technique or with ultrasound. Phono may be difficult with the short, large neck masses, limited neck extension. Provide previous head and neck surgery or radiotherapy. Although phono is the last resort in the cannot intubate, cannot ventilate situation, but it may be the initial plan of choice in case of anticipated difficult airway. Assess the trachea via cricothyroid membrane or between the tracheal cartilage ring below if you are planning for tracheostomy. DAS guideline educates surgical cricothyroidotomy rather than needle cricothyroidotomy in an emergency using a scalpel, bougie or tracheal tube. According to the studies, the needle techniques have a higher failure rate. The optimal position for performing front of neck axis is with head and neck extended both, because necking position is not good for the front of neck axis. Along with the extension of the head, neck extension should also be ensured. This is a landmark technique. You can see it's called laryngeal handshake, through which we can identify Adam's apple, the thyroid cartilage below which the cricothyroid membrane is present, and which is the choice for the front of neck axis in case of cricothyroidotomy. This is the DAS guideline for cannot intubate, cannot ventilate situation, in which it is a planned scalpel cricothyroidotomy could be performed. Equipment which should be used: scalpel, bougie, and tube, about 5 to 6 tube. Laryngeal handshake to identify cricothyroid membrane. Palpable cricothyroid membrane should also be considered. If it is the case of difficulty like obese patient, so non or impalpable cricothyroid membrane should also be considered. Tracheostomy. In a cannot intubate, cannot ventilate situation, we perform emergency tracheostomy in the children less than 8 years, and a scalpel cricothyroid technique in children older than 8 years. Phono may be performed awake under local anesthesia if there is concern of losing airway once asleep. Ideally inserted between the first and second tracheal ring